Great. Thank you, Stephen, and thank you for the invitation. Thank you, everyone. Good day to you as you're joining from around the globe. I'm really thrilled to have this conversation with you on optimizing cancer survivorship and cardiovascular outcomes and what are our gaps and opportunities. I'm a medical oncologist and I focus exclusively on the clinical care of men and women with breast cancer. And my research and administrative roles are on symptom management, cancer supportive care, and I work closely with the Cardio-Oncology team here at Ohio State. So our agenda is, I would love to interact with you on this case-based discussion, so feel free to share your thoughts and also put questions and comments in the chat. I think part of the mission of these series is that different specialties can interact with one another and learn from one another. So I look forward to definitely hearing your thoughts. My focus is on the intersection of cardiac issues that happen in the setting of caring for patients with breast cancer, and the themes that you'll see pop up throughout the presentation include shared risk factors between cardiac disease and breast cancer, how these can complicate our treatment decisions, both as oncologists as well as cardiologists, and how we can't really take out what we call social determinants of health, issues related to access to care, finances, culture, and how all of these can impact how well patients do with both their cardiac disease as well as their cancer history. It's helpful to maybe start with some definitions of survivorship and survivors. Who are they, and what is the connection with cardiology issues? Since we have a heterogeneous group in attendance, I just wanted to kind of cover very briefly the basics of breast cancer, which, as many of you know, is a very common cancer. And as breast specialists, we like to think that based on years and decades of research, that it's really not one disease, and there are many different subtypes of breast cancer, and they all behave a little differently. For our purposes, the idea of putting them into these three buckets, with the most common type being this endocrine positive, ER positive, PR positive, HER2 negative breast cancer. And the patient in my case that I will be presenting is in this bucket. So just kind of keep that in mind, that she has an estrogen-driven breast cancer. And then much less a subject of this talk, but I'm sure has been covered in the past or will be, is the HER2 positive variety, because they're often treated with HER2-directed therapy, which can have significant cardiovascular outcomes as well. And then we have the bucket of what we call triple negative breast cancer, where all three markers are negative. And this is the group that most often now is receiving anthracycline therapy, as well as immunotherapy in select cases. So obviously all of these have cardiovascular implications as well. So in terms of cancer survivor population, it's growing, and people refer to this silver tsunami that will be happening by 2040, where a large majority of our cancer survivor population in the US will be older, and this also applies to other regions of the world, including Europe, Australia, and parts of Asia as well. And so, as I mentioned, projected is that the majority of our survivors will be older, and it's well known to this audience that as humans get older, their cardiovascular risk factors also tend to increase. So this is part of the connection. In terms of the most common cancer survivors in the US and in the world, breast is one of the most common, where men and women diagnosed with breast cancer, no matter what their stage, due to the combination of the disease type as well as the available treatments, they tend to live many years after their diagnosis. So this presents the situation where, as we take care of their cancer, there are also a lot of chronic comorbidities that need to be taken care of, and that, of course, includes cardiac issues. Before we go on further, this is not meant to be a trick question, but either think in your mind or shout out or put in the chat if you feel inclined, in terms of how you, in your mind, define a cancer survivor. And no matter who the audience is, whether they're oncologists, cardiologists, or various specialties, people tend to have very personal definitions of who a cancer survivor is. So think about that for a minute, and if you would like to share, feel free to share that in the chat or out loud or to yourself. The most common way people define a cancer survivor, they tend to think of it as somebody who's done with all their treatments, could be 5 years out, or just completed all their treatments. So these are some of the most common ways that people think about cancer survivors. But I do want to highlight that really the official definition, really the definition that really defines the field of cancer survivorship, is that it really starts much earlier than many of us like to think of. It really starts from the day one of the cancer diagnosis, and it goes through the balance of his or her life. And just like there are many different types of cancers, there are actually many different types of cancer survivors, including those who are living with ongoing cancer and cancer treatments, and those free of cancer. And so this is quite relevant for the cardiology, oncology relationships that we develop with all of you, in that as you see these patients, it's really important to kind of try to think about where they are in their treatment. So they could be in that acute phase where they're receiving treatment, then they transition into this possibly cancer-free extended survivorship period. Then we often see these late toxicities, including late toxicities from anthracyclines and other cancer related therapies in patients who are sometimes decades from their original cancer diagnosis. But then the subject of our case is actually what we call chronic survivorship, which is patients can be living with active cancer and still having ongoing cardiac issues, and that will be what we will be focused on. And since our case is about breast cancer, I just wanted to kind of further highlight the survivorship issues of advanced, metastatic, or stage 4 breast cancer. These are all the different ways that people refer to this type of breast cancer. And you certainly can have patients who unfortunately deteriorate very quickly, but then you really have a sizable population who can live with advanced cancer for a very long time or have a very stable phase. And the cardio-oncology issues are very relevant for this population because they're getting a series of treatments, and they're often competing risk factors for both the cancer as well as cardio-oncology. and kind of just further putting kind of cancer survivorship within a framework. This is the National Cancer Institute framework of cancer survivorship and all the different areas that we focus on. And you can see that the field of cardio-oncology really touches on so many of these factors. If a patient develops a recurrence or a new cancer and they need additional therapies that may be cardiotoxic, obviously physical effects and cardiac toxicities are one of the rings. Chronic conditions that I'll touch on in the case, such as traditional risk factors like high blood pressure and hyperlipidemia and diabetes, all of these really fall within this framework of cancer survivorship. So the purpose of this slide was really to highlight that there can be a lot of synergy and collaboration between cardio-oncology and cancer survivorship. So moving on to our case vignette, this is actually the story of my patient in clinic. I have not altered the details other than taking out any identifiers, but it really highlights that these are the type of situations that we're seeing in clinic. So she's a 63-year-old Black woman who noted a mass in her right breast. It persisted for a year, and she was between jobs, had limited insurance access, so she could not get it immediately evaluated and eventually sought evaluation for this mass a year later. She underwent standard imaging and biopsies, which revealed that most common type of breast cancer that I had highlighted before, which is that estrogen receptor positive, progesterone receptor positive, HER2 negative breast cancer. She underwent surgery, and you can see that it was pretty extensive disease that had spread to multiple lymph nodes. Whether that would have happened if she had sought earlier attention or not, nobody knows for sure, but certainly earlier intervention for breast cancer has been associated with better outcomes. And because this was falling into what we would call like a pathological stage 3 disease at the time, she went on to have staging studies that unfortunately did reveal that she really had spread of the breast cancer to other parts of the body, particularly in the bone area, which tends to be the most common area of initial metastasis for breast cancer. And obviously and understandably, she was very shocked with this diagnosis. And normally we like to confirm that this is indeed metastasis by a biopsy, but she did not want to undergo too much diagnostic or interventional workup. And so in the setting of metastatic ER positive breast cancer, estrogen-driven breast cancer, the standard of care is anti-estrogen therapy, and letrozole is one of those class of drugs known as aromatase inhibitors, which lowers the available peripheral conversion of androgens and other pre-estrogen analogs to estrogen. So it's a standard of care. And I'm not going to focus too much on the targeted therapy that was offered to her, but we often couple our anti-estrogens with additional targeted therapies, which could have additional toxicities and side effects. And she really had a hard time kind of coping with the diagnosis. She had some side effect issues and really did not like to take oral drugs. So she did hold it for a little bit of time until she adjusted to the diagnosis. And then as far as we understand, she did end up just taking the anti-estrogen pill for over a year and a half. And her disease was stable. These estrogen-dependent breast cancers tend to respond very well initially to anti-estrogen therapy. They don't immediately need chemotherapy. In this interval, I'm her oncologist, and she also has a primary care provider. And, you know, I'll talk about some of her chronic medical problems, but, you know, we have the primary care provider, you have me. She doesn't at this point have a cardiologist. Are we really interacting with one another? Maybe very peripherally, which is kind of part of the system issues in terms of how we deliver healthcare, really in any health system. She eventually progressed in her breast cancer. So we did more scans, and there was more bony involvement, and it was really clearly time to change. And so she was changed to another anti-estrogen, and she finally agreed to start a medication for her bone metastases to stabilize the bone mets. And it was at this point that she had either presented to her primary care provider or to a local ER with some chest pain symptoms, and workup really led to the diagnosis that she had really active coronary artery disease, and she had to undergo a PCI. And you know, as an oncologist, obviously I get these reports and I'm noting this, but my focus and the focus of many oncologists is going to be still the cancer. And so obviously I was relying on her cardio-oncology team, her cardiology team, and her PCP to kind of be spearheading that aspect of her care. But kind of like in thinking back, you know, what led to this woman in her 60s to kind of present the way she did with her cardiac event, and, you know, looking at her cardiac risk factors. She had poorly controlled blood pressure and hypertension, and just as much as she had issues taking some of her cancer drugs, she also kind of struggled with affording some of her blood pressure medications, and for a variety of reasons, and no way blaming her, because I think she has a very complex life. She also struggled with managing her diabetes, and she had a high body mass index. So obviously these are her known cardiac risk factors. But then there were also other life issues going on, which made it more difficult to manage both her cardiac disease as well as her oncology needs, including you know, there were gaps in insurance coverage, transportation issues. There were issues about, you know, coming to medical appointments, you know, for valid reasons of being an underrepresented minority in a health system that has not always acted in a very just way, talking about healthcare in general. She was very fearful and distrustful of medical tests and procedures. And she's not alone in terms of her presentation, and this is well known to this audience, that, you know, when we look at our cancer population, those with baseline cardiovascular risk factors tend to have more cardiac events. This was a study done within the cooperative group setting, Southwest Oncology Group, by Dr. Don Hirschman and group. We can clearly see that the, you know, baseline high blood pressure, baseline diabetes, the presence of cardiac risk factors was strongly associated with future cardiovascular adverse events. And also she, as you recall, at this point she was in her mid-60s, and we know that these are obviously associations. I'm not talking about causation, but these are the associations that we're seeing with cardiovascular disease and breast cancer specifically, which having these cardiovascular risk factors can be associated with worse cancer-related outcomes. And you can conjecture that this is due to a variety of reasons, including that these cardiac risk factors can impact how well, as oncologists, we're able to give these types of therapies, our cancer therapies, but also that some of these cardiac risk factors could actually negatively impact how tumors respond and do over time, including metabolic effects that can actually worsen how a cancer does over time. And so when we look at older cancer survivors, again, not a surprise to this group, but cardiovascular disease actually can compete with breast cancer as the leading cause of death in older survivors. And this is all stages, not specifically speaking of metastatic breast cancer, but again, really highlights how close collaboration between our groups is so essential. Another study that just came out of Australia just in the last few weeks similarly is highlighting that in all cancers, not just breast cancer, cardiac deaths tend to essentially compete with cancer-related deaths as we kind of go further along in time since diagnosis. But what about her cancer therapy? Kind of opening it up again to discussion before I present my slides, which is, as you recall, she's on, she has all these other reasons to have a cardiac event, but she's also, I've been giving her anti-estrogen therapy for at least 2 years by the time she had her first cardiac event. So kind of think about, you know, whether that may have contributed to her cardiac event. Thoughts on that? Feel free to put it in the chat or shout it out or think to yourself. So obviously, as oncologists and cardiologists, we're used to thinking about Herceptin and doxorubicin as kind of the most common, or immunotherapy as the most common causative agents of cardiac issues in the cancer population. But what about endocrine therapy or anti-estrogen therapy? And the links are not as well worked out as some of those most immediately recognized cardiotoxic medications, but certainly there is a body of work that has seen associations with our anti-estrogen therapies and cardiac risk factors or even cardiac events. For example, with the aromatase inhibitors, the drug that she was initially on, both hyperlipidemia as well as cardiac events in general are more common compared to the older drug tamoxifen. You know, there are different hypotheses and different thoughts about why that could be. Tamoxifen is a completely different type of estrogen receptor modulator. So one of the thoughts is that tamoxifen is actually protective against heart disease. And so it's not so much that the aromatase inhibitors are worse on the heart, but that when we compare these two drugs, tamoxifen is protective. So it looks like the aromatase inhibitors are maybe more detrimental than they really are. In terms of how for a lot of our breast cancers, younger women, or we are essentially putting them into an earlier menopause, either through having an oophorectomy or by suppressing ovarian function through chemical ways. And so I'll show you a few slides about how ovarian suppression, we do have data that in itself could potentially elevate cardiac risk. But in terms of the cardiotoxicity of aromatase inhibitors specifically in postmenopausal women with breast cancer, the largest study was a meta-analysis of 19 trials in patients who were receiving these agents, and compared to tamoxifen, there was an increased relative risk of 19% compared to tamoxifen for all different types of cardiac events seen in this population. But when you actually compared it to placebo, that was not seen. So this is back to the conjecture that maybe it's not so much that the aromatase inhibitors are necessarily causing cardiac events, but that tamoxifen may be more protective. But when we actually look at estrogen suppression by itself through, women who've had a bilateral self-angioophorectomy, definitely we can see that there are associations with increased cardiovascular disease and heart disease in these studies, as you can see there. And then one of our large international studies also looked at tamoxifen plus monthly injections to suppress ovarian function. And in this particular study, there was a higher incidence of high blood pressure in the women who were receiving aromatase inhibitors. So you can see that, yes, regardless, even in patients on tamoxifen, you have a good proportion of these women, and this is a younger population that needed ovarian suppression, who have cardiac risk factors that need to be actively monitored and addressed. So moving on back to our case, she unfortunately, as happens with many types of breast cancers, there is a period of stability, and then there's the tumor cells adjust, as I like to tell my patients. They acquire new properties for growth, and so they go on to new areas, and so she had further progression in the bone and possibly in the liver. We gave one last try to endocrine therapy agents, but she was really progressing. She was continuing to progressing, suggesting that even though the tumor was initially estrogen dependent, it was no longer primarily driven by estrogen related pathways, and we needed to think about switching therapy. And there were a lot of different chemo agents I could have chosen in this setting, but she really felt strongly that she wanted to do an oral type of therapy. And one of probably the most recognizable oral chemo agents that we can use in breast cancer is something known as capecitabine or Xeloda, which is a prodrug of the chemo drug that you may more immediately recognize, which is 5-fluorouracil or 5-FU. So she went on that drug, and there were adherence issues, but she was taking it, and she actually called our clinic saying she couldn't breathe, that she was having crushing chest pain, and she was obviously referred emergently to the ER, where she underwent cardiac catheterization, and her old stent had occluded, as well as there was a new area, which I'll cover in the next slide. Obviously, it was a very, very hard experience for her, for somebody who is not comfortable in the healthcare setting. It was a very challenging experience to have kind of this acute presentation of a ST elevation MI. And when I saw her back in clinic a few weeks later, she felt profoundly fatigued, and just was really, did not want to immediately jump on resuming any type of therapy. You know, this is well known to many of you, which is kind of our different chemo agents certainly can have potential cardiovascular effects. And capecitabine, you know, obviously with the anthracyclines and the HER2-directed therapies, as I mentioned before, those are most recognizable. And with capecitabine, there have been reports that it can lead to vasospasms, acute coronary syndrome, but it's not the most common presentation. It's something that it's an agent that we use quite often, and I would say within 15 years of practice, I may have had one such case where on this therapy, patient kind of presented acutely with a cardiac event. So how much of it was the capecitabine? How much of it were her other cardiac risk factors? And this is the cardiologist notes, so you can kind of get more of the impression of kind of what they saw. So kind of there was the stenosis and the proximal LAD, as well as occlusion in the LAD. And she, keep in mind for some of the subsequent slides that she was noted to have a reduced ejection fraction, and she had been on beta blocker and ARB therapy prior, but she had also been on amlodipine, and so this was discontinued in favor of kind of pushing the cardioprotective effects of the beta blocker and the ARB. And as you recall, she had kind of a long-standing hyperlipidemia. And she had been previously on a high-dose statin, and so additional agents were recommended. And I think in all of these, I think you know how adherent for a variety of reasons she might have been with some of her existing therapies. I think she had many struggles in terms of staying on the therapies that have been previously recommended. So how much of this was difficult to control cardiac risk factors and cardiac disease, and how much of it was an adherence issue? I think it's a mix of the two, for sure. But it just really highlights kind of the complexities of taking care of these patients that we both see our respective groups in our clinics. And so the cardio-oncology team did not feel strongly that I needed to hold the capecitabine. They felt that, you know, how much of it was really causative for a cardiac event. They were not completely convinced. And at the time, it looked like she had been, you know, taking the oral chemo drug and reasonably liking it, as anybody who could like an oral chemo. So we made the decision when she felt ready to resume the oral chemo. So her cardiac event was in November, and just this month, when I scanned her, she it looked like she was not responding to capecitabine. So it was, again, very traumatic for her, coming back within 2 months of a myocardial infarction and then having to deal with her cancer progression. And she did admit that maybe she had missed some doses of the capecitabine, and she really did not want to undergo a biopsy. And so she really felt strongly that she wanted to continue the capecitabine. And so I convinced her that we could continue for a little bit of time and then do short interval scans. And if her liver is continuing to show lack of response, we would need to change her treatment, which at that point would be intravenous chemotherapy. And so this kind of brings up the next discussion point, which is, you know, she's never had anthracyclines, which is, you know, one of our foundation drugs in breast cancer. She's not had taxanes. She prefers not to do IV, but the reality is, whether in the next scan or in a scan 6 months from now, I will be looking at having to change her therapy if she wants to continue further therapy. And I think she should, because essentially she has a number of additional options for her breast cancer treatment. But the question is, you know, how can we do it safely with her cardiac disease? So many of you know that in the early stage breast cancer, we typically use doxorubicin or epirubicin as our anthracycline of choice. In the more advanced cancer setting, we tend to use something called Doxil or liposomal doxorubicin, which tends to be both better tolerated in terms of a lot of other cancer treatment toxicities, but also tends to be a little less harsh in terms of cardiac issues. So it's something that I was going to go back and talk to her cardiologist about, which is if I had to if I wanted to use liposomal doxorubicin, how risky is it in the setting of this recent MI and this depressed EF, now that she is on beta blocker, maximal beta blocker and ARB therapy? And my suspicion is that the answer would be that it's probably too risky, but I think it would be interesting to kind of hear your thoughts kind of when we open it up to discussion in a little bit. But so it just kind of highlights those dilemmas, right? I know she would tolerate liposomal doxorubicin a lot better than a weekly taxane where she has to come to clinic every week. But just how she'll do with her cardiac issues and whether we would want to take that risk is the question. And
so question.
Yeah,
this is Jose from WashU. How much time between the heart attack or event, between that time and when you would consider starting treatment with the doxorubicin, how much time are you willing to wait until she recovers from the heart attack? What would be the time frame that you would give the cardiologist?
Yeah, I really appreciate your question. Thank you. So since she really does not want to change her therapy right now, my bargain with her was April, where we would scan. So her cardiac event was in November. So if I need to change therapy in April, it would be approximately 5 months. And I imagine that we would repeat her cardiac imaging again and get an updated measure of her cardiac function, either by echo or by cardiac MRI, or in addition. So yeah, so I would say it would be 4 to 5 months. Tell me more what you're thinking.
Oh, this is Joe.
Yeah, so I mean, I think that it was in November, and if she's otherwise doing okay, and she has no heart failure symptoms, it's recent. I would recommend doing the cardiac MRI because it's going to give you more information about, ventricular remodeling, is there scar tissue, and you'll be able to risk stratify the patient a little bit better. It seems that, yeah, it was a significant event because it was in the LAD and her ejection fraction dropped a little bit. But, if there's not, if not enough remodeling has occurred so far and she's been on therapy, there's a chance that she might recover and continue with chemotherapy again. We'll have to see what the MRI shows after being on therapy. But I think that it would be, a possibility that she can get treated. The other question I had is, you talk about the liposomal doxorubicin in breast cancer. What about, I know that, it's difficult to get it approved, but what are your thoughts on using dexrazoxane prior to doxorubicin in this patient if your ejection fraction remains 45%?
Yeah, great question. So it's a question that I actually asked. So in terms of cardioprotection, it hasn't taken off for whatever reason in breast cancer. I think it's certainly used, from my understanding, more in the pediatric populations. In the curative setting, I think there are theoretical concerns that it may make the curative intent less curative, so I can understand that. But to your point, a patient who has advanced cancer, has active cardiac issues, why wouldn't we use it? And the only other thing that I can think of, other than insurance coverage and that maybe we just don't think enough outside the box, is I believe there's also some like bone marrow suppression issues that sometimes have been reported. I don't have a good answer for you. It's a question that I asked as well in terms of why we don't use that agent more. At least in the advanced cancer setting when we're using these cardiotoxic agents. I'm interested in the group's thoughts.
So from our experience here with the sarcoma, our sarcoma group, that they use a lot of anthracyclines. Actually, there's a publication that it's about to come out over the next couple of weeks or months about the effectiveness of using dexrazoxane as a protective agent in these patients, and they were able to get treated with astronomical doses of anthracycline, and the results were pretty good. So that's basically why I was asking, but I know it's a sarcoma, it's not breast cancer.
Yes, no, I think it highlights the silos. In breast cancer, it has never taken off, and if there are other breast cancer experts on the webinar, I would be interested to hear your thoughts. But I think it's particularly going to be helpful with these Doxil patients because they often, in the metastatic setting, sometimes can be on these drugs, on Doxil, for a very, very long time. So I think it would be very interesting to look at that and even kind of conceive of a study looking at that specifically for the advanced cancer population. I really appreciate your comment. So, so this is again well known to this audience that with the classic anthracycline and trastuzumab population, heart failure issues, cardiovascular disease, as well as arrhythmias are common with these agents. And then in the remaining few minutes, I just wanted to kind of just further brainstorm opportunities, and I have a few slides, but before I go on, I wanted to see if there were additional questions on this particular case before I talk more generally in terms of just kind of cardio-oncology care in the context of survivorship care. Are there additional questions or comments about the case specifically?
Looks like Stephanie Feldman had a question. Stephanie, you want to jump in?
Oh, sure. I was more just commenting that I think, Jose, as you had talked about, I don't feel that her presentation, her cardiomyopathy would necessarily be prohibitive for her getting the liposomal doxorubicin. It's the best treatment for her cancer. You know, she's definitely increased risk, as Jose had said, but I think if she's on good medical therapy and you're obviously going to follow her more closely than somebody without cardiovascular risk factors with echo and probably global longitudinal strain monitoring, then I think that that's okay. The other piece I just wanted to bring up was I'm not sure where her blood pressure, her lipids, or A1C were throughout all of this, but those are the other things aside from ejection fraction to really hone in on and to focus on with her. And then the last piece is and I apologize if I missed this, it sounds like she struggled psychosocially with her diagnosis and with medication compliance and things. And the question I have for you and the group would be, what other resources or things did you use or are you using with her? Or do you think that would be helpful aside from, you know, chemotherapy and prescribing medications that would really help to engage her and maybe her family to help her with these things?
Yes, really appreciate your very astute comments. In terms of psychosocial oncology support, we have offered. One of the things we do in our cancer center is the use of navigation for particularly high risk, underserved populations. And I think definitely there's a body of evidence that cancer navigation for these types of higher risk population can help with missed appointments and kind of identifying barriers and access to care. In her particular situation, I think there was additional complexity of her really wanting to have as little to do with healthcare, anything as possible. So anything that I tried to kind of add on was just another burden for her due to a variety of reasons. But I think in general, I think certainly referral to psychosocial oncology for better coping, navigation. I think peer support. We have a program called HOPE where patients are matched to representative peers, so who are trained, but the idea of kind of seeing you know, a fellow individual who is going through or having gone through a similar cancer diagnosis is something that's been helpful to other patients. But I think specifically for her, I think something that I think would have helped her probably, and we are in the process of setting up, is having another African-American peer who was trained and could specifically kind of culturally navigate her. I think that's an opportunity that we're working on expanding, and I think that may have helped her maybe trust the healthcare system more. So those are some of my thoughts.
Yeah, really challenging. Thank you.
Good morning, Maryam, and good morning, all. This is Daniel Addison from Ohio State. Outstanding talk so far. I was not involved, but I would wonder with this patient, did she maybe express maybe additional specific reasons for her, maybe her mistrust or level of difficulty with care?
Yeah. So thank you, Daniel. Great to hear you. And I will admit, Daniel, that perhaps I could probe more. And I think this again highlights how all of us can have better training in terms of being more culturally sensitive and in tune as we see patients who are distrustful of the medical system. I think I want to reiterate that just speaking in general, I'm sure the patient had experienced events throughout her exposure to the healthcare system from the time she was young to now, where she may have been treated unfairly and unjustly. And obviously we know that there is systemic racism that's rampant within our healthcare system. But I'll be honest with you, Daniel, I did not probe. And I think these are opportunities in terms of how, as oncologists, cardiologists, how each of us can kind of be more actively engaged in these social determinants of health, which clearly are impacting care. Like, we can't be thinking we're taking good care of patients if we're not addressing them. To share exacts of her prior experiences, I will be honest that I did not delve. I think it's an important question you're asking.
No, and you know, Maryam, I've always felt that you deliver outstanding care, and I know that you do, and I know that you care for these patients. You know, I find, and I admit sometimes in these scenarios I have a slight advantage being a Black cardiologist, but you know, there are these unmeasured factors that often factor in, and people, they may not speak about them so readily, and that may impact how they view and decide to engage with what we recommend and so forth. And I know that you're making efforts for this. So
Yeah.
my hope would be even for.
And kind of echoing Dr. Capers, who many of you know, who is a well-known cardiologist, I think this is why representation is so critical, where, you know, just as she interacts with more members of the healthcare community who are Black, and I think that's part of the trust building that has to happen, and that's why diversity issues are so important.
As always, though, you know, I know that we're moving in the right direction, and you're delivering outstanding care, and we're going to always continue to work together to move in that direction. So thank you. I'll let you continue your talk.
Of course. So no, I mean, I've enjoyed this discussion, and I think feel free to jump in. I think these slides are less important, but essentially, I think this dialogue is further highlighting for me just how important the mission of your society, our society is that oncologists, cardiologists, and primary care really, we need to work very closely together. And it's just so many different buckets that we need to focus on. And I know a lot of these efforts are going on by all of you. And I think, as was kind of further mentioned by several of you, and as I mentioned in the talk, you know, we've talked about her secondary cardiovascular events, but really kind of opportunities for primary cardiovascular prevention is such a key thing in taking care of these patients, and how we actually implement that, and how we actually disseminate kind of, we know what to do, but just how do we get people to kind of address these risk factors. I think it's something that, you know, it's challenging. And in survivorship, we like to talk about the teachable and learnable moment. And often for many patients, the cancer diagnosis, it can be an awakening of, gosh, maybe this is the time that I need to really take my health very seriously. So I think engaging with patients is key, because we think we know what they want. And back to that other excellent question, which is really taking patients who are really struggling in the healthcare system and really qualitatively understanding what can we do better, what can we do to kind of streamline how care is given and make it more effective. You know, in terms of exercise, I just wanted to give a shout out to some of the people in the group who have published this recent publication, and there is a guideline coming out soon on exercise and metastatic cancer as well. So just like we would advise being as active as possible in the early stage setting, I think this is an area that we also need to focus on in the advanced cancer setting. And so she certainly is sedentary and really focusing on that exercise prescription and how to make it more widely used. I think these are questions beyond the scope of this talk, but obviously these are our gaps. Our patients are obese, they're not exercising, and they have terrible lipids and blood pressure issues, and these are things that we need to work on together. I think it goes without saying that as oncologists, it's like cardiac health is absolutely a concern and should be a concern for us, given all the things that we talked about during this talk. It impacts what drugs I can give, the toxicities, as well as it impacts directly patient related outcomes in terms of cancer survival. So our goals are the same. So let's continue to synergize. I would love to think about potentially a collaboration on the Doxil question. I think it would be very relevant to the oncology community and the cardio-oncology community. And so happy Heart Month. And thank you for having me.
Hello.
Yes.
May I intervene?
Of course.
This is Agnese Maria Fioretti, Bari, Italy, Cancer Institute. I'm impressed by the introduction of your talk. Congratulations, because you highlighted the importance of the psychosocial issue. And my question is about the use of complementary therapies in survivorship care. So about the use of music therapy in breast cancer patients, because there are some papers about the evaluation of the heart rate variability during music therapy in breast cancer patients. So I would like to know if do you use this kind of care in your institution? Thank you very much.
What a wonderful comment and question. So yes, I'm definitely aware a little bit of the emerging data related to music therapy, art therapy as well as just a fascinating field of heart rate variability as a predictor of a lot of different outcomes in cancer. To answer your question, it's back to integration. You know, we talk about integrative medicine being integrated, but it's actually very challenging to integrate it. So we actually have an ambulatory referral to music therapy, which, you know, we can put into our electronic medical record. Patients get scheduled. There's actually no cost associated with it. So fantastic. So that's one of the blessings of our cancer center, which is well endowed. But it's not integrated, meaning that even though I'm the director of supportive care services and I kind of have my hand in the pot with a lot of these things, I can tell you that I never thought about even referring this patient to music therapy. So again, it just highlights how things exist in silos and pockets, but to really integrate them seamlessly and really reduce the burden on patients, that's a whole issue of implementation science. And how do we do that? And how do we do that? So I think it's a brilliant suggestion. It could have been helpful to her. I imagine she would have said, I would do it if it came to me while I was getting treatment, so I didn't have to take extra time to do it. But it just how do we kind of bring in all these support services and seamlessly integrate it with cancer care? it's really tough to do that because we like to kind of put things in pockets. And there's space issues and flow issues and sometimes reimbursement issues. In some ways, like, we need to even like rethink how we deliver cancer care. So it's an important question, and yes, we have it, but we're not using it as much as we should.
Thank you. Congratulations.
Well,
Thank
thank you
you,
so
everyone.
much. Yeah, thank you, Dr. Lustberg, so much for your presentation. Great discussion, and just really appreciate having an oncology perspective presented in this series. So we really appreciate it. Next week there'll be at the same time a presentation related to imaging and cardio-oncology. So hope you all can join us next week. And thank you again, Dr. Lustberg, and thank you everyone for joining today.
Thank you.
Thank you very much.